This topic is arthroplasty. Pathophysiology. Arthroplasty is the surgical replacement of a synovial joint with implants. Remember, a synovial joint is where two bones come together, but they are not joined. The joint is surrounded by smooth cartilage and contains a synovial lining and fluid for smooth movement in bending and moving. The most common joints replaced are the hip and knee, but I have seen the shoulder and ankle also replaced. Joint replacements can be total or partial. A total arthroplasty, or total joint replacement, is when the entire joint is replaced with implants. It generally will involve the two surfaces that come together in the joint. When it is a partial, it is called a hemiarthroplasty, as seen in the image here. The femoral component is implanted, but the acetabular socket was not replaced, making this a partial hip replacement, or hip hemiarthroplasty. A client may also require a revision. A revision is after a client has had a primary arthroplasty. This may be replacing all of the components or just some of them. Indications. Joint replacement is normally done for pain control and mobility improvement. The pain may have steadily increased and is now affecting the client's everyday life. Or the client's mobility may become limited and the client will seek out a solution. Causes of that pain and immobility include osteoarthritis. The cartilage is damaged, and this can be due to age or obesity. Osteonecrosis, the death of bone because blood supply was cut off, so no blood supply, no oxygen results in death. That could be from excessive alcohol use, long-term steroid use, or broken bones. Rheumatoid arthritis. This is an autoimmune disease that results in inflammation of the connective tissue in the synovial joints. Congenital anomalies. A baby born with functional or structural anomalies. Knee or hip fracture. You can see in the image two of some of the numerous areas the hip can be fractured. On the left, a femoral neck fracture, and on the right, an intertrochanteric fracture. There are also clients who have had previous arthroplasty, and the components have failed or loosened, and these clients require an arthroplasty revision, like we spoke about earlier. Complications. Infection. An infected joint can be detrimental for a client. It may require long-term antibiotics, a revision, and oftentimes, if the joint is infected, the surgeon needs to wait until the infection has cleared before placing new hardware or implants. Deep vein thrombosis, or DVT, which can lead to a pulmonary embolism. Older clients are at an increased risk for this, and that's generally who most joint replacements are performed upon. To prevent DVT, there are different interventions that are included in a client's care. The client should have proper hydration, early ambulation and exercises, and anticoagulant therapy. Clients may have persistent pain and swelling, which can then lead to limitations to function and mobility. This will affect their daily lives and possibly the ability to care for themselves. Age-related considerations. Older adults. The majority of clients undergoing total joint replacement are over 60 years old, and this age group is at higher risk for complications. They have more comorbidities. Older clients enter surgery with more comorbidities than would a healthy younger client. The older client may have hypertension, chronic obstructive pulmonary disease, diabetes, kidney disease. These all affect them during the procedure and also during recovery. And they are on more medications, maybe anticoagulants, insulin, steroids, blood pressure medications. All of these will affect the client during surgery and post-operatively during recovery. Preoperative nursing interventions. We need to check for signs of a current infection, like a fever. Due to the risk of developing an infection in the joint, most surgeons will not perform surgery with implants on a client with an infection anywhere in their body. We need to check the client's ability to learn and understand teaching. Did they follow the pre-op instructions, and can they follow the post-op instructions? We can help them identify a joint coach and include that person in the teaching. It could be a family support person or a caregiver. The client may meet with physical therapy to learn transfer techniques, proper use of devices, and to practice exercises. The client and caregiver learn these before the surgery. Then that information can be reinforced at the time of discharge. We want to teach infection prevention. They may be instructed to bathe the day prior to surgery and morning of surgery with a specific soap. We need to review current medications. Some may need to be stopped prior to surgery, and provide teaching for new prescriptions, like analgesics. And we will administer intravenous antibiotics as prescribed, normally 1 to 2 hours prior to surgery. Post-operative nursing interventions. We will be monitoring all the things we normally do with a post-op client, with a couple extra focus steps. We'll monitor their vital signs and mental status. Are they stable? Are they waking up from surgery properly? Arthroplasty is done under different types of anesthesia: spinal, monitored anesthesia care, MAC, or general, or a combination. You need to know what type your client had. Check the operative site for bleeding and edema. And check circulation of the affected extremity, those neurovascular checks. Distal pulses: is the foot the same color and temperature as the other foot? Sensation, capillary refill. An abduction pillow may be placed between the legs after the lateral or posterior approach is used for hip arthroplasty. A special pillow is placed between the legs, or a couple of regular bed pillows can be used. This will help the client avoid adduction. A common complication with hip replacement surgery is dislocation of the hip joint. This is more common with the lateral and posterior approaches because of how the surgeon gains exposure and access to the hip joint. With these two approaches, the client should avoid adduction to prevent dislocation. But dislocation is less common with the anterior approach, and pillows between the legs are not normally used for clients who had the anterior approach for a hip replacement. We will encourage the use of incentive spirometry. We will inspire the client to encourage deep breathing, which will help prevent atelectasis and pneumonia. And we will implement mobility exercises as soon as possible and as prescribed. All those exercises they learned preoperatively, and we will reinforce whatever the physical therapist has planned. We will administer antibiotics, again to prevent infection. An infected joint can be detrimental for a client. Pain control with administering analgesics, and we can apply intermittent cold packs to the surgical site. Some clients will have cryotherapy, an ice circulation pad that is wrapped around the joint. Client teaching. We want the client to inspect their incision daily for redness, drainage, and swelling, looking for those signs of infection. We want to make sure that the client uses their assistive devices as instructed, like grab bars, raised toilet seats, walkers, and railings, to assist with mobility and activities of daily living, and to avoid complications or falls. They should avoid driving until approved by the healthcare provider, and adhere to the recommended mobility exercises and limitations. And when exercising, they should have frequent rest periods. We want them to do the exercises, but not to overdo it. In their home, they should minimize clutter to decrease the risk for falling. like removing area rugs and making sure walkways are clear of clutter. Keep up the great work. I'm proud of you.